Good morning, everyone. This is one of the problems of megalocornea. When SFIL, there is high chance of IOL decentration. So one of the cases presented to us a young 5-year-old child who had decentered IOL after 1 year of surgery. So it was planned that the IOL will be the same IOL will be fixated. First of all, the IOL was hooked out from the scleral pocket where it was fixed using silk hooks and the forceps. It was dialed out into the anterior chamber. And before entering the anterior chamber, we had already made flaps along the vertical section. We chose the vertical section.
It is audio. Sir, can hear you better. Yeah. Sorry. Yeah.
The vertical diameter was chosen because it was smaller than the horizontal diameter naturally. After the IOL was dialed out into the anterior chamber, the MVR entry was made through the iris, as we can see here. Through the iris, behind the IOL. So this was a trans-iris bypass. As we can see in this diagram, the y is smaller than x. So when we make the path along the iris and we exteriorize the haptic anteriorly, the distance is smaller and the amount of fragment that is exteriorized is larger. Similarly, on the other side, the trans-iris route was made for exteriorizing the haptic. So after stabilizing it in anterior chamber, the forceps were passed through the iris and the haptics were guided from posteriorly to iris to the anterior flap. This is the trans-iris bypass technique. After getting firm hold of the haptic, it was exteriorized through the iris. There was slight resistance, but it was gradually pulled out through the iris. This minimizes the distance the haptics have to travel to be exteriorized. The similar thing was done on the other side. Through the peripheral iris, the haptics were exteriorized. The other haptic was held just to make it more stable. Thus on both the sides, through the iris, the haptics were exteriorized along the vertical meridian of the eye, in contrary to the horizontal meridian. It was done because this was a case of megalocornea in which previously SFIL was done and the IOL had decentered. Thereafter, the haptics were tucked in the scleral pockets and pilocarpine was injected to constrict the pupil. the trans iris bypass along the vertical meridian significantly decreases the distance the haptics have to travel and make them more stable, especially in eyes with megalocornea. Similarly, the other haptic was also tucked in the scleral tunnel. Thereafter, scleral flaps were closed using fibrin glue and conjunctiva was also closed. Follow-up, the patient had a centered, well-centered IOL. This tells us that trans iris bypass along the vertical meridian provides a very stable position in cases of eyes with megalocornea undergoing scleral fixated IOL.
Very nice. I've done this for patients who got high myopia. Only thing is, I don't go with the meningotomy knife through the iris because sometimes you can produce an hydrodialysis. So what I do is with a cutter, I make a small iridectomy and then go through that and bring that haptic through that and externalize that haptic. That can be done. The only problem is because you are a little anterior, there is a possibility of a pupillary capture. Have you noticed anything like that?
Yes, sir. In this particular case, there was no pupillary capture, but because there was even this patient, he has maximum dilation of 5.5 only, and however, since it was very stuck to the back side of the iris, we have done only few cases. We have done only 2 cases. So in those cases, we have not observed. However, there might be a chance in case in which after dilation there might be a chance that there will be pupillary capture.
There's a possibility. Sometimes.
There's a possibility.
Sometimes I do a pupilloplasty as well.
Yes, sir.
So to make sure the pupil does not dilate and cause a pupillary capture. Because once a pupillary capture occurs, the lens can start tilting and it can produce astigmatism as well. Why not an iris claw lens?
Sir, that is also one of the possible
Very
options.
simple, no?
What is
But usually
And did you observe hyphema in any hyphema post-op in?
no, sir, there was no post-operative hyphema.
For the sake of the endothelium, what is your preferred choice of viscoelastic in cases like these? This is to sir also actually. Because again, washing you have to be careful while washing.
No, this scleral fixation, we don't use any viscoelastics. We use either an anterior chamber maintainer or we use a pars plana infusion, depending on your comfort level. So everything is entire ball game is on fluids, no viscoelastics, because viscoelastic can go and mix with the vitreous, can produce severe inflammation, secondary glaucoma, and all these problems.
Yes, sir. AC maintenance
Yeah.
was